And one of the questions, we know that in a statin, the age limit is 8 years. Below that, still not recommended. And they are asking about, maybe Dr. Naji answered this question in your algorithm, other medications like ezetimibe and other PCSK9 and other medications. What is the age limit?
Yes, for statin can be used even up to age of 8. It can be used, statin. However, low doses of statin. PCSK9, like evolocumab, they get approval below 18, but still not beyond 10 years of age. Lumitabide can be used, but again, not lower. Although I know most of the time people, they use like statin in those people. Ezetimibe can be used even in the lower age, like even less than 12. Liver transplant is a better option for them if they have like family history of familial homozygous hypercholesterolemia.
And what about if he's a small child and all the medications, as we know
LDL pharynx is a good option for them.
It's not available. This is one of the questions. It's not available.
Statin and ezetimibe.
Even if he's less than 8 years?
With statin and ezetimibe can be used, plus monitoring as well as specialized clinic for those.
Yeah, actually we can, but it's off-label. It's not yet recommended below this age. There was a question about the valvular involvement. Is it usually due to hyperlipidemia, or there is another syndromes can cause that the presentation? Is it due to hyperlipidemia?
Oh, yeah. So in these patients, it's a very common problem that a lot of these patients get referred, and one patient got referred as a Takayasu cardiomyopathy. One other patient was said, oh, this guy has a bicuspid aortic valve. No, this is because homozygous familial hypercholesterolemia. From the very beginning, in the 1950s, we already figured out that is caused directly. When you do pathology, you see lipid crystals in the aortic valve.
Okay.
It goes throughout from the valve, from the tips all the way to the ostium of the coronaries. So this is definitely because of homozygous familial hypercholesterolemia.
Do you have a control group for your cohort?
So these are patients on my clinic. So it's a registry that we're just following these patients.
Okay.
And seeing them how they proceed and how things go. So we're just seeing how the treatment is, documenting what's going on, and seeing how they do in their surgeries. But it's not a case control kind of series. It's a very rare disease, but hopefully, inshallah, with collaboration, something could be planned like this, but it's a very difficult thing to do.
Thank you. Dr. Abdurrahman, there is some questions about inheritance and we know that homozygous, heterozygous, combined, and so on. But some questions, the mode of inheritance, is it from the father side or mother side more?
So it is inherited as autosomal semi-dominant inheritance. So if the patient inherits one mutant allele, either from the father or from the mother, he will express heterozygous familial hypercholesterolemia, which is less severe form of the disease. However, if the patient inherits two mutant allele, one from each parent, like one from father and mother, he will have the more severe form of the disease, the homozygous effect. So it is autosomal dominant. So just inheritance of one mutant allele from each one of the parent will express the disease.
Yeah, when asking if my uncle, that Khali, from the mother's side, what should I do?
Yes. Regarding this question, it is very important to address the importance of family screening and cascade screening. When we look at the data, so doing family screening and cascade screening will identify 50% in the first degree relative, and 25% in the second degree relative, and 12.5% in the third degree relative. So you can imagine how many cases we can identify by doing cascade screening. So to address her question, yes, she needs to check her cholesterol because there is a risk that she might have the condition.
Okay.
Sorry, Doctor. I just want to make one additional comment for this. So one of the things that's important, so they have the disease, that one of the things that could be offered is for these patients, especially if you have a homozygous who's marrying a heterozygous, or that one of the things that could be done is very helpful, and we're starting to do it right now, is IVF
Okay.
for child planning.
Okay.
And this could be very helpful. So although the patients will still have a heterozygous, it's much more easier to manage than another homozygous. So that's something the patients should be aware, and we're fairly new getting accustomed to these utilizing these technologies, but we've sent several patients for IVF, and helpful for family planning when they're about to, when they get married, because they're now getting older, pregnant, and married, and all these things, and it's important to have this option also, and be aware of this.
Just to comment, even for primary prevention, even if he doesn't have family history, he need to be at age of 20 to 40 at least once, at least every 5 years, to have screening of lipid profile. However, this is not necessary to be fasting. If their triglyceride is than 200, this will be varied, even if it is not fasting, because LDL will be more accurate. If this is more than 400, they need to have repeated in a fasting state at least 10 to 12 hours. They can drink water, but they cannot eat any food.
Thank you. Dr. Hani, there is a question actually regarding the risk factors. What is the most avoidable risk factor you want to encourage to avoid, not to develop cardiovascular disease due to hypercholesterolemia? And the other thing, what is the most effective program publicly to prevent such diseases?
So I think we need to focus on what the WHO has called best buys. That means that applies in every country, in every socio-demographic population. And that is in fact smoking, right? This is all about lipids, but we completely don't talk about smoking. And smoking is literally going to cancel basically the benefit of almost all of the therapies we talk about. And this is a problem we have in the Middle East. It's really a huge one. So I would say if there's any health behavior that needs to be addressed in the Middle East, we need to think that shisha is not safer than smoking. We have to address cigarette smoking and shisha and vape and all this stuff as a completely negative thing, just like it is in the West. We have children who use midwakh. I don't know if this is a common problem here. It's a disaster, really. So I think that's the number one thing that we don't tackle as physicians. This is a more health system issue and an educational issue. The second thing, I think, if you look about LDL is very poorly controlled in our region, and it's due to multiple reasons, right? Sedentary lifestyle is the norm. When you go to Abu Dhabi or Dubai, people are not running on the corniche, they're sitting, having something to eat, or using the shisha. Again, we don't encourage healthy lifestyles, therefore you have obesity, metabolic syndrome, it's all looping into the same factor. So you have the polygenic factors, which I'm sure there's a lot of that, and we also have sedentary lifestyle. So if you want to tackle one thing, right? Hypertension is difficult because it has multiple different facets. Diabetes is even more difficult, right? Weight loss and smoking are behavioral issues. If you have one thing that you can target as a government, as a ministry, as a public health program, you can tackle LDL. It's a simple test, it's cheap, it's very effective. You have a lot of treatments that are available that have evidence-based medicine is just beyond discussion. And I think that's what we need to do. What we've been working on is using a former version of the app that we used for COVID-19. It now flags the LDL. It tells the patient, look, your LDL's in the red, please go and see the doctor. If they get enrolled in the program, we recommend they're on statin ezetimibe, then it flags again, you're still not controlled. So it's a constant reminder, and it literally is telling them something that they're familiar with, which is COVID-19, but they don't like, with something that's painless that they won't recognize unless we push them. That's kind of the story.
Thank you. Dr. Hajar, there is a question saying that when we'll see the results of the registry, and do will help in tackling the effect of medications, the new medications and the expensive medications, or not? Mm.
So one of the objectives of having these registries is getting some sort of fieldwork data on our population or patients, analyzing the adherence, analyzing the lifestyle, and this will reflect on the efficacy of those medications on our population. So it would give us more room of negotiation, more room of analyzing different endpoints that we need to see, and then find whether the patient would be proven or it would be a failure by definition of these endpoints. major component of these.
And when will we'll see this result?
Probably would go in a couple of 2 weeks between us and Amgen to just negotiate the outcomes of those clinic. But we're going to have a publication, inshallah, on the effects.
Thank you very much. Thank you very much. It was lovely to have you today. And by this, we conclude our lovely day. Thank you for organizers, Fatma, and your organization from the morning. And thank you for our speakers, eminent speakers from the morning until now. And thank you very much for you, audience online, and those who've been with us in the hall. Thank you very much.